All right, hello everyone. We're going to go ahead and get started. Welcome to today's Future Direction of Lab Medicine webinar on optimizing cancer care, the ASCO guidelines for germline genetic testing. I'm Dr. Bobby Pritt. I am the Division Chair for Clinical Microbiology at Mayo Clinic in Rochester, Minnesota. And today I'm delighted to introduce our presenters, Dr. Wei Shen, an assistant professor and expert from the Division of Laboratory Genetics and Genomics, and Carrie Lehner, a skilled genetic counselor from the Department of Laboratory Medicine and Pathology, also here at Mayo Clinic. So now I'm going to turn things over to our presenters.
Thank you, Dr. Fick, for the introduction here, and thanks everyone for joining the webinar today. We'll be discussing the ASCO guidelines for the germline cancer genetic testing that was published early this year. So Carrie and I does not have any financial disclosures, and also off-label use of medications would not be discussed today. So this is the learning objectives for today's webinar. We will provide an overview of the ASCO guidelines for cancer germline genetic testing in the context of current genetic testing environment. And we select a few, specific examples, to illustrate how we can use the ASCO guidelines for cancer patient testing here, and also illustrate some of the challenges that may associated with the cancer genetic testing. Hopefully by the end of the webinar today, you will be able to determine the appropriate gene panel testing based on the patient's personal and family history. So we know that hereditary cancer syndromes are genetic conditions, characterized by a significant increased risk for developing cancer. Over the several decades, numerous those cancer syndromes has been discovered, and a number of genes has been identified as well. So here's a two diagram showing that the common genes involved in various cancer types. I'm not going to go through each one of them today, but just to showing you that the extensive knowledge is needed to fully understand those cancer gene associations. So here's a table to provide another perspective regarding cancer gene associations here. As you can see from this table, most of the gene listed here actually have multiple cancer associations. For example, BRCA1 and BRCA2, those are the two probably most well-known gene for breast cancer. They actually is also associated with a higher risk for ovarian cancer in women, and along several other cancer types. Similarly, those four mismatch repair genes that are associated with Lynch syndrome is also connected with a broad range of tumor types. So this complicated gene cancer association is the key factor driving the increased complexity of germline cancer genetic testing today. So what kind of features that will make us suspect of a hereditary cancer syndromes? First of all, if the cancer has early onset, for example, the patient has breast cancer diagnosed before age of 50, or colorectal cancer diagnosed before age of 45, or the patient has multiple primary tumors in the same individual. For example, the patient has bilateral breast cancer or bilateral ovarian cancer, or breast and ovarian cancer, etc. And also family history is also very, very important, as we'll see later throughout the webinar today. Does the patient has, first or secondary relatives has cancer? If so, whether the cancer is the same type or different type from the proband. The last thing, rare tumor types or unusual, pathological features of the tumor. For example, male breast cancer may be indicated for BRCA1 and BRCA2, and osteosarcoma may point you to the lymphomania syndrome. For the past decades, next generation sequencing has really revolutionized in how we perform genetic testing. Previously we're focused on a single gene or maybe a couple of genes, by Sanger sequencing, and interrogating the genes separately or individually. But now, since the introduction of NGS, the field has shifted towards multi-gene panel testing. So this allows us to simultaneously testing multiple genes without increasing cost and time. As the sequencing cost continues to decrease and the capacity for data analysis and sequencing throughput increase in whole exome sequencing, whole genome sequencing has become now emerging as the first diagnosis for rare disease. As for cancer testing we're talking about today, the targeted gene panel still remains as the mainstream testing approach. So germline genetic testing, once limited to specialized settings, is now widely accessible. Options range from single genes to multi-gene panels for cancer-specific gene panels to broader pan-cancer panels. However, despite the availability of testing, access to genetic professionals such as genetic counselors and medical geneticists still remain limited. The impact of germline testing has also expanded beyond risk management. For example, in the BRCA1 or BRCA2 pathogenic variants are now guiding therapeutic decisions. The use of PARP inhibitors, which has become a standard of care for in the setting of metastatic breast cancer. As genetic testing become more common, the responsibility for offering it has extended beyond genetics professionals to include oncologists, surgeons, and primary care providers. So this shift underscores the importance to develop, the professional society-specific guidelines to help navigate the complexity of genetic testing in routine patient care. So we know that breast cancer it involves multiple high-risk genes beyond BRCA1, BRCA2. Despite of that, the BRCA1, BRCA2 are still commonly performed, at least in our laboratory, due to the main concerns for insurance coverage beyond the BRCA1 and the BRCA2. And sometimes it's, personal preference. For those testings, BRCA1 and BRCA2 is primarily referred to us for testing due to personal or family history of cancer that is related to those two genes, mainly breast cancer, ovarian cancer. At the Mayo Clinic laboratory, we do use a slice testing approach, meaning that we perform exome sequencing for anyone that referred to us for germline genetic testing. But we only report and do the data analysis only for the specific genes that included in the specific panel that has been ordered. I think this allowed us to perform a retrospective review of this patient cohort that has undergone the BRCA1 and the BRCA2 gene testing to answer the question: is this sufficient to test just those two genes? So here's what the data has been showing there. So we have, we have expanded out the genetic testing results beyond the BRCA1 and BRCA2. In this patient cohort of 1,000 individuals here, we identified 71 individuals carried in a pathogenic variant or like in BRCA1 or BRCA2. So this is still the most common findings in the testing here. But the expanded testing also revealed that in other 55 individuals actually had clinical significant findings in genes beyond BRCA1, BRCA2, those including in other high-risk genes for breast cancer, such as PALB2. And interestingly, it also increased, high-risk genes for other cancer types, for example, the APC or other mismatch repair genes, things like that. And of course, including pathogenic variants in those moderate risk genes. So this data clearly shows that, the benefits of broader gene testing, but the question becomes how broad we should go. Given the increased complexity of germline testing, its growing role in therapeutics and the limited access to genetic service, oncologists are increasingly involved in ordering germline testing. So in this context, ASCO seeks to establish oncology focused, guideline for germline cancer genetic testing with the four main purposes listing here: identifying the components of family history most relevant to germline testing, understanding the potential benefits and harms of ordering multi-gene panels, identify the most relevant cancer susceptibility genes to include in a multi-gene panel on basis of patients' personal and family history of cancer. and also understanding when germline genetic testing is indicated for patients who have had tumor genomic profiling. So the ASCO guideline is developed by a multidisciplinary expert panel, which includes the field experts and also patient representatives, and also ASCO guideline staff member who has expertise in establishing, healthcare research and guidelines there. And then the guideline was developed based on a systematic review of the literature and other existing guidelines from other organizations, including a total of 52 documents. Mostly, majority of them is published since 2014. The grade system is used to assess the quality of the evidence. Once the guideline was drafted here, it was posted for a period of public comment, open comment period, and with the feedbacks being carefully evaluated, and then before the final approval by the ASCO evidence-based medicine committee here. So with that, and I'm going to hand it over to my colleague Carrie to dive into the details of ASCO guideline recommendations. So Carrie, please.
Thank you so much, Dr. Shen. So Dr. Shen set a wonderful background for the group here, just understanding the necessity on why these ASCO guidelines were developed, and I'll dive into each of them in a little bit further detail. But the first clinical question that the expert panel was really asking was around what is the importance of that family history collection in the setting of germline multi-gene panel testing? And then to follow that, what elements of the family history were most important? We've got a few pictures of pedigrees here, which are commonly known tools in the genetics world on how we capture some of that family history information to provide risk assessment and really highlight the patterns that Dr. Shen was talking about earlier in terms of red flags for hereditary cancer syndromes, whether it be the type of cancer diagnosed, seeing multiple tumors in the same individual, age of diagnosis, or observing the same type of cancer across multiple generations. But what we know is that this family history collection is really central to all of our genetic risk assessment. It assists us in determining the most appropriate genetic test to order, but then also helps us to understand the interpretation of those test results and our cancer risk assessment for the patient based upon those results. We can also use it as a tool to help understand what other family members could benefit from increased screening or prevention opportunities, and then to customize some of those genetic cancer screening recommendations based upon the results. So for instance, in a family who has a pathogenic BRCA variant identified, if there's no family history of pancreatic cancer among those family members, they may not need to consider pancreatic cancer screening as significantly as a family who's presented with that type of cancer. So really, it's a dynamic tool. It's something that is recommended to update on an annual basis because we know that the types of cancer which are diagnosed or information about the cancer diagnoses in the family can actually change over the period of time as well. So when the ASCO group sat down and looked at all of this information about the utility of cancer family history, they came out with the recommendation, a strong recommendation, indicating that all patients should have a family history taken and recorded on the basis of all of this evidence. We recognize that there is a limitation in some understanding of family medical history or biological relationships, which may have not been discussed previously among the family relationships there. So we understand it may be incomplete, but that process of initiating the discussion by medical oncologists and by other clinicians is so valuable, as it may help to fuel that patient with additional discussion among their family members after it's initiated. And what we know from the genetics field in general is that family history is the most cost-effective genetic screening test. It's really necessary in oncology to select the correct genetic test and subsequently interpret those results. Next slide, Dr. Shen. So they did go on to help us understand a little bit further about what questions should be asked when we're looking at the family history. The importance of family history, as I stated, has been well known, and this recommendation has existed for over a decade, actually, that was published originally by Liu et al. In 2014. But this expert group really sought to provide some additional clarity to the language that was proposed. And this included calling out those biological relatives to help minimize potential for confusion. So this first specific question that's recommended by ASCO to be asking when taking a family history is, does the patient know of any cancers in first-degree biological relatives? And those are defined as siblings, parents, or children. Then following that up with whether or not the patient knows of cancers in any second-degree biological relatives. And it's important to clarify that this is both on the maternal and paternal sides of the family. These relatives would include grandparents, aunts, uncles, grandchildren, nieces, nephews, and half-siblings. For each of those cancers that are diagnosed in the family, it's important to follow that up with an understanding of the following details. What type of primary cancer was diagnosed? What age was that diagnosed at? And whether or not multiple cancers of one type were involved. So to have an aunt with breast cancer, clarifying the age, but also was it unilateral or bilateral? Were there the possibility of multiple colon cancer primaries that developed in one single individual, as that obviously indicates a higher likelihood of a genetic predisposition? Question 4 is around whether or not the patient understands if any relative has historically had germline genetic testing for cancer predisposition, and if so, what were those results? That's important because if that hereditary predisposition has already been diagnosed in a family, instead of going along with the recommendations here for multi-gene panel testing, where we're looking at and sequencing a number of different genes, we actually can focus in on only that specific genetic risk factor, which has been identified historically in the family. And that helps to clarify the significance for that particular individual. And then question 5 was, what is the patient's ethnicity? Important to document because we know certain cancer types are higher prevalence in certain ethnic backgrounds. Next slide. So in follow-up, we recognize that collection of family history can be difficult. Clinical schedules are busy. And so I wanted to provide a few resources to assist you and your patients in collecting this information, potentially either in the office or something that a patient could gather ahead of time. There's a number of resources on the Center for Disease Control and Prevention website, which includes the link here that you can access following this webinar. But then also the Surgeon General has a tool called My Family Health Portrait, which is a patient-facing collection tool that individuals can access and actually save their data to be gathered at a future time frame or updated as necessary. And so feeling free to share either of these particular resources with your patient population. But I think the My Family Health Portrait is a really unique and helpful resource for patients who want to begin collecting that information and then potentially update it as more information is known over the course of time. We've also done a few podcasts recently in the month of November, actually, because Thanksgiving Day is recognized as National Family History Day, as it allows for more conversation and discussion, hopefully, around a gathering of relatives and family members. But these were both recently published here to again highlight the utility of some of that family history information as well as the important questions to ask. So if you're looking for additional resources, we'll send out those along with the webinar. Next slide. The second question that the expert panel sought to really understand was when and how multi-gene panel germline testing should be used, or when germline genetic testing is indicated. And what I appreciated about the group looking at this was that it's a really serious undertaking. As Dr. Shen had commented earlier, in light of so much advancing genetic technology and the increasing availability of genetic testing, it can be hard to sort through which of these genes are most appropriate for patients with given clinical conditions. And so the panel really wanted to provide clarity for practicing clinicians on what was beneficial while balancing the advantages and disadvantages of genetic testing. What we've come to understand in genetics is that bigger is not always better in the world of genetic medicine, as some of these genes which can be tested still have a limited clinical utility. There's also a potential for identifying variants of uncertain significance, which do not offer significant benefit beyond the patient's cancer family history alone. And this can subsequently increase that patient's anxiety or uncertainty about a stressful topic. So they sought to really understand how this testing should be used and when, because they also understood that it can add to the efficiency of a testing approach to do a multi-gene panel test and improve the turnaround time of those available results. And so ASCO guideline recommendation 2, which was also rated as a strong recommendation, is that when germline genetic testing is indicated for a patient with cancer, multi-gene panel testing should be offered if more than one gene is relevant. Next slide, please. So the group was really looking at these principles to help guide this recommendation. That the minimal panel, which is proposed for that patient's test, should include at least the more strongly recommended genes for the patient based upon their personal and family history of cancer. And this is all listed out in Table 1 of the publication in this guideline. It may include some of the less strongly recommended genes, but it should include those which are highlighted in the first column as more strongly recommended. They also indicated that a broader panel may be ordered when the potential benefits of such a panel can be clearly identified, and that when ordering this panel, especially in the setting of a broader panel, the clinician should ensure that potential harms for that patient are mitigated. So there's a little bit additional detail related to those harms, which could be considered in the clinical interpretation section of the guideline. They did acknowledge that smaller panels of genes may be tested initially when those results are needed quickly for treatment decision-making, and that you could continue to consider reflexing to a subsequent expansion of a larger panel of genes once those initial genes are interrogated. And so we see this often in clinical practice where we have just a small set of genes where we know that a patient they have a high degree of medical actionability. And so a patient may make different decisions about the upcoming surgery on the basis of those test results. But then having the opportunity to reflex to a larger panel of genes, which may take a little bit more time for those results to come back, is certainly important. Next slide. And so just a few additional considerations when clinicians are sitting down and thinking about which panel is most appropriate for testing in this particular patient scenario. A few factors to consider would include something like the potential for unreliable family history information. How good of a historian is that patient who's providing family history information? Whether or not there's a high prevalence or significant medical actionability of the genes that are not implicated by personal or family history, increased anxiety for that patient about variants of uncertain significance and those types of results. Whether or not there's a potential for misinterpretation, unnecessary surveillance, or other risk reduction efforts. And recognizing also that the reason sometimes these multi-gene panel tests are more appropriate is because the estimates of cancer risk which have come out are based on those patients which have historically been studied with a characteristic personal or family history of cancer. It may not apply to all. And so really, it's important to consider each of these patients' preferences and their tolerance regarding the uncertainty versus the desire for more information when selecting the best multi-gene panel for testing. One of the interesting things that came out, though, from this recommendation as well, and we'll talk about this a little bit further when we're looking at the recommended genes from table 1, was really related to the significant prevalence and the significant medical actionability of a few of those hereditary cancer syndromes that Dr. Shen mentioned in the beginning. So hereditary breast and ovarian cancer syndrome due to BRCA1 or BRCA2 pathogenic variants, or Lynch syndrome, have such a high degree of prevalence and actionability that the ASCO guideline actually recommended that genes associated with both of these syndromes should be tested whenever multi-gene panel testing is ordered. Next slide, please. And so now diving into the real meat of this conversation here, which genes are generally recommended for germline genetic testing for patients with selected cancer? As Dr. Shen mentioned, the expert panel really reviewed documents that made specific recommendations for testing of these particular genes, and then broke this down by cancer type to include syndrome-related genes across all of the relevant cancers, and the number of publications that recommended this testing. So this gave them that rough estimate of the amount of evidence that was needed for that particular gene. They then divided these into various subtypes and subgroups so that those groups could further dive into the details of that gene and published an initial draft recommendation. So these lists included those that were associated with a moderate lifetime risk of cancer and those that had clear medical actionability based upon the results. That draft went through an open comment period and was verified against one of our professional organizations. The ClinGen working group has an online database that they verified the results against, and then their final recommendations were published in Table 1 of the ASCO recommendation publication. So this table then is further divided into two sections of more and less strongly recommended genes to test. And they indicated that those which were more strongly recommended should be tested in all patients with that cancer subtype. So again, a strong recommendation by the group here that says, if germline multi-gene panel testing is offered, testing for pathogenic variants in the genes in Table 1 is recommended for the indicated population of patients with cancer. And so those which were targeted as more strongly recommended were those with a higher relative risk, which is greater than or equal to a 4-fold increased risk, or those which had higher actionability, so preventative surgery consideration, etc. The less strongly recommended genes were those which had a moderate relative risk of less than 4-fold increased, and the potential actionability may or may not may be as significant as those in the higher groups. So next slide, please. An example of a few of those here, just a small subset of those cancer types, strictly here for example, so I encourage you to access the full publication. They chose those cancers which were relatively common and likely to have a hereditary component to the disease versus those which were more likely to be attributable to non-genetic causes. So you can see here, for patients with breast cancer, the more strongly recommended genes includes those that Dr. Shen highlighted in the beginning: BRCA1, BRCA2, POLB2, CDH1, PTEN, STK11, and TP53. But then also on that list of less strongly recommended genes, again, which could be offered depending on the patient's tolerance for uncertainty and variants of uncertain significance could also consider including ATM, BARD1, CHEK2, RAD51C, RAD51D, and NF1. And this goes on in that table 1 with the number of different cancer subtypes. So publication is referenced at the bottom here for further information related to that. While we certainly understand the utility of this germline testing to make decisions related to some treatments, such as PARP inhibitors, the expert panel actually refrained from commenting on that, as it was just determined to be beyond the scope of this particular guideline. And so only looking at the genes for germline genetic testing, not treatment decisions. Next slide. I wanted to share an example here too, just to understand a little bit more and set the context for the group on what the process of curating these multi-gene panel tests looks like in a current laboratory practice. So you'll see here, it's broken down into 4 parts, and they all kind of rely upon one another as we're making some of these decisions here. But of course, the consensus among the key opinion leaders, like the ASCO guidelines, which are published here, are part of that decision making when we're bringing up a certain assay in the laboratory and deciding which genes should be unmasked from the testing technology. But we're also doing a manual review of our experts in the laboratory to understand the clinical utility and basing that off of some of the management guidelines which exist, as well as publications and literature which highlight the relative risk of developing cancer, and then also our testing technology and what is the diagnostic yield. We also look to some of our expert guidelines here, like ClinGen, as a resource to understand the gene curation framework for which they've proposed and whether the evidence is definitive, strong, or moderate. And then, of course, having the value of Mayo Clinic and a collaborative organization, both laboratory and clinical partnerships here, we can rely on the expertise, which is honed in on just by our particular laboratories. So once the ASCO guidelines came out, we were happy to see that the panels which we had already developed meet or exceed what was recommended by them. And so we're definitely in line with all of those. But our approach, I think, is unique in that it's really designed with a patient in mind rather than a one-size-fits-all approach. Next slide. The last of the recommendations that the expert panel came out with was focusing on which of these patients should be offered germline genetic testing if they have or will have somatic genetic tumor testing or tumor genomic profiling in addition to considering germline testing. And this was a question that was really somewhat separate from the initial evidence curated. So the group took a step back and found some additional literature, 14 studies, which reported the prevalence of germline genetic findings in addition to tumor testing findings. However, in the midst of this process, they also became aware of a parallel initiative by the European Society for Medical Oncology Precision Medicine Working Group, which was assimilating similar data from a large volume of patients with paired tumor germline results. Both groups divided the genes into 3 actionability classes, those which were most actionable, highly actionable, and had standard actionability. And then using those classes, they presented 4 potential approaches to mitigating results and directing testing in this subset of patients, which they termed permissive, intermediate conservative, and then conservative. So ESMO, European Society for Medical Oncology, formally recommended an intermediate conservative approach in their final guideline, but noted that other approaches may be suitable. And so when ASCO considered, the expert panel considered all of this information, they came out with these recommendations here that were more in line with the permissive or intermediate permissive approaches. Guideline 4.1, again, a strong guideline, indicated that patients who meet criteria for germline genetic testing should be offered that testing regardless of the results from tumor testing. And this was based on the evidence from previous publications, again, which noted about 10% of germline pathogenic variants are actually missed if clinicians are relying upon tumor testing alone. This could be due to the fact that the laboratory may have used various algorithms that would have filtered out some of the germline genetic testing results and narrowed it down to only most relevant results for treatment, or some of their limitations of technology to detect certain genetic aberrations such as CNVs or intronic variants. The second part of this recommendation then related to who should have this testing is that regardless of those germline genetic testing criteria, when a pathogenic variant is identified with tumor testing in a gene listed in the table 2 of the publication, germline genetic testing should be offered according to these criteria. And so again, this was based upon the fact that a number of publications have identified germline pathogenic variants in patients who don't meet specific criteria for testing, but still have these relevant variants identified by tumor genomic profiling. So to break this down a little bit further and kind of lay it out in an algorithm here, next slide, please, Dr. Shen. The panel took into account a number of these factors, including that increased likelihood of identifying germline pathogenic variants in the more permissive approaches, with the increased burden of performing this testing across a large percentage of patients, and also the value of simplifying the recommendation to make it easier to translate into the medical oncology community. They ultimately achieved this consensus on a hybrid of the ESMO's recommendations for permissive and intermediate permissive approaches. So this algorithm here is adapted from Table 2, but also from a subsequent publication here by Ricker et al. In 2024 to try to simplify the details a little bit further. But when I say hybrid, what I'm really pointing out here is this permissive approach is indicating that any patient who has a pathogenic or likely pathogenic variant identified by the tumor testing should have follow-up germline testing for this subset of genes here grouped in the red box on the left. So BRCA1, BRCA2, etc. And if those patients were diagnosed at an age less than 30, they can also consider testing these APC, PTEN, etc. The intermediate permissive group, again, depending on that patient's tolerance and desire for more information, can consider germline testing if a pathogenic or likely pathogenic variant is identified in those genes in the orange box. And then the more conservative, intermediate conservative approach here is listed in the yellow box, that patients there can have germline testing offered if that less conservative testing approach would be desired. I'm going to pass it back to Dr. Shen now to continue walking through some cases.
All right, thank you, Carrie, for the detailed discussion on the ASCO guideline recommendation there. So in the rest of the seminar today, we're going to be present a few cases to illustrate how we can use the ASCO guidelines for to guide us for cancer genetic testing here. So the case one involves a 41-year-old female patient who actually diagnosed with bilateral ovarian cancer at age of 41. She also had a tumor testing that identified a BRCA pathogenic variant here, as per the guideline, ASCO guideline Carrie just presented here, our germline testing should be followed, the tumor testing in this individual. In this case, we did the germline testing using a blood specimen and confirmed that the BRCA pathogenic variant is actually truly a germline variant, and this helps establish the diagnosis of hereditary breast and ovarian cancer syndrome in this individual. And we know that this is a cancer syndrome that is characterized by increased risk for breast and ovarian cancer. And also there's higher risk for other cancer types too. So there's a very nice table from Gene Review that summarized the individual cancer risk here. In terms of the management, for this condition, which includes enhanced surveillance for patient who was test positive. That includes annual mammogram and breast AMR study at a younger age, and also the risk reduction. Prevention surgeries can also be considered, and more important, as we talked about this already. The BRCA1, BRCA2 pathogenic variants actually can make the patient eligible for PARP inhibitor treatment. So case 2 involves this 35-year-old female patient who in 2018 had a soft tissue mass identified and surgically removed, and later was identified as a paraganglioma. And 4 years later, she had metastatic disease into the bone and lymph nodes. Here's the family history revealed that she had a paternal uncle who had bile duct tumor, and she also had paternal grandfather who has a colon cancer here. So based on the clinical presentation here for this particular individual, the ASCO guideline will recommend this is the following genes to be tested in here. So eventually this patient is elected or selected a hereditary paraganglioma and pheochromocytoma gene panel, which ultimately identified SDHB likely pathogenic variants. And this is the kind of more information on the SDHB. At the end of last year, an international expert consent statement was published regarding the management of pheochromocytoma and panganglioma in patients with germline SDHB pathogenic variants. Given that SDHB is associated with aggressive, recurrent, and often metastatic tumors, and with high rates of morbidity and mortality, early surgical intervention and a total tumor resection is recommended regardless of the tumor size. So this is another example to showing that the germline genetic testing results is directly influencing the surgical decisions. Case 3 involves this 31-year-old female patient with colon cancer, and then, as you can see from the family history, she's from a family with multi-generation individuals with diagnosed with colon cancer, endometrial cancer, ovarian cancer at relatively young ages. And then, so this is a highly suspected genetic etiology of cancer syndrome in this family. And then this individual and her cousin actually had a tumor testing, which identified a loss of MH1 and PMS2 in the tumor. So this is another strong indication this could be a Lynch syndrome related condition here. So given the broader tumor run through the family here, this individual and her cousin eventually go through the genetic counseling and elected to do a broader gene panel testing for a panel that covers both colon cancer, endometrial cancer, and ovarian cancer that has been seen in this family here. And surprisingly to us, the testing for a broader gene panel actually can come back as negative. So this outcome really made us think, what we have been missed here. So as geneticists, we're putting our detective hat on and dig deeper into Lynch syndrome related mutation spectrums here, and we actually realize there's a small portion of Lynch syndrome patients actually is resulting from this phenomenon called what we call constitutional MH1 promoter hypomethylation. So this is only a very small portion of MH1 related Lynch syndrome cases here, but it does happen. There's about 140 individuals across 100 families has been reported so far in the literature. There's two main sources of MH1 promoter hypomethylation. One is that a primary epi mutation. This often is sporadic. The second one would be the secondary epi mutation. Due to some primary genetic etiology at the DNA level. So I think our standard gene testing focus primarily on the exon region or the intron exon boundaries where the most of MH1 pathogenic variants occurs. So the Lynch syndrome, due to the MH1 promoter hypomethylation, will not be, detected by a typical standard NGS-based testing. So fortunately, there is a test that we can use to detect, constitutional ML1 promoter hypomethylation, and this is what we did for this patient and also her cousin, and it turns out they are both positive for the constitutional MH1 promoter hypomethylation. So this actually helps establish a Lynch syndrome in this family. So build on upon this case here, we actually went back, did perform a retrospective review of all individuals has gone through this constitutional MH1 promoter hypomethylation test. So we, about over 400, individuals go through this testing. We identified 66 6 patients actually tested positive, it's about 16%. And then among those, we performed a further, research study like sequencing the MH1 promoter regions. We identified, among those, about 18% of those individuals positive for CMPH actually had rare variants in the promoter regions, and this prevalence is much higher in those familial cases. This is actually provides a strong support for there is a primary genetic etiology behind, the MH1 promoter hypomethylation. So case 4 involves in this 26-year-old female patient, who actually had adrenal tumor diagnosed at a pretty young age, 2 years old, and later at 16 years old, she had osteosarcoma. And the family history, in contrast to the previous case, is not that significant. She had a paternal grandmother had skin cancer diagnosis at the age of 78. She had a maternal grandmother who has breast cancer diagnosed at 92 years old. So, according to the ASCO guidelines, germline TP53 gene testing should be performed. And it's actually identified a pathogenic variant in the TP53 genes, and this confirms the diagnosis of Lynch syndrome. And then the patient was counseled that the risk for her children to carry this particular same variant is 50%. And due to the unremarkable family history, the patient was also counseled that this is likely de novo events in her. So at this time, all data points to this will be a typical Lynch syndrome. And later, this patient actually underwent the IVF with implementation genetic testing, to try to have a healthy baby, given that the high, reproductive risk here. So she had underwent 2 cycles of IVF, which produced 9 viable embryos, and all the 9 embryos are tested negative for this particular TP53 variant. So we're just wondering, what's the likelihood of this happening? Statistically, this should be less than 1 in 1,000. So either we're really lucky here, or there's something else is at play. So the genetics eventually raised the possibility of a mosaicism in this individual, and we went back to her original, genetic testing results. That TP53 mutation variant actually occurs about 31% in terms of variant allele fraction, in the blood. So this is low compared to what we typically see for heterozygous variants, but it's still above the kind of a 30% cutoff, for people would suspect, mosaicism there. So we did testing additional 3 tissue samples here: saliva, skin fibroblast, and then colon tissues here. And in all 3 specimen types reviewed variable variant allele fractions for this particular TP53 variant. So this confirms that this individual is actually a mosaic for Lynch syndrome here. So the question becomes, how does this change the genetic counseling for this patient here, right? So I think given that none of the embryos actually tested positive for the TP53 variant, it's likely that the percentage in her germinal tissues is actually very low, if not absent, and her reproductive risk will be low. So this case highlights the challenge in interpreting TP53 variants, particularly in the case of low variant allele fractions, right? So there's a multiple mechanism can result in low VAF here. Mosaicism is one of them, as we see in this case. The second one would be the clonal hematopoiesis, often involves in TP53 gene. So distinguish those mechanisms can be a challenge, but we have general principles and tools that can help us, right? If you see a older individual who had TP53 variant in their blood testing, whereas the person does not have lymph-remaining spectrum tumors, you may want to suspect that clonal hematopoiesis there. And then analysis from other tissue types, like what we did in this case, can help clarify the mechanism. So another key aspect of cancer genetic testing is pre-symptomatic testing, which the ASCO guideline did not specifically address. One of the primary benefits of pre-symptomatic genetic testing is the potential to detect an increased cancer risk before any symptoms or signs of cancer can occur, right? So knowing that they are at high risk allows individuals and their healthcare providers to tailor proactive screening and prevention strategies and even treatment plans according to their specific, risk profiles. This is what we call the personalized medical care. Knowing genetic cancer risk can also empower individuals to make informed decisions about their healthcare and lifestyle choices. This also have implications for family planning, also healthcare implications for other family members. It's also important to know that there is psychological, emotional challenge aspect for pre-symptomatic testing. So that's why it's not appropriate for everyone. The decision to undergo pre-symptomatic genetic testing should be made only after carefully consideration and counseling with the healthcare providers. So this is just a quick case to show that utility of the pre-symptomatic testing here. This is involves this 23-year-old individual who has a mother and a multiple maternal aunt that has diagnosed breast cancer at young ages, and then the mother actually tested positive for BRCA1. And she was referred to plastic surgery and genetic counseling for potential risk management there. Since there's a family variant, detect here, there's two options we can do. Or we can just go target, which could be cost more effective, just testing that particular familial variant, or we can have this option to go with gene panel like we do with the patient with cancer here. Eventually, this patient elected to do the targeted approach, and then unfortunately, she was tested positive for the familial variant. The use of large cancer gene panels for germline cancer testing has become more and more common. So the ASCO guidelines calls out, as Kerry pointed out, that for the needs to balance the benefits and the potential risk here. So while larger panels can uncover unexpected but clinically important findings, they can also make interpretation more complicated here. So this is the exact same data I showed at the early of the webinar, at the beginning of the webinar, but in this case, we just color-coded the genes based on the ASCO, guideline categories there. For example, the blue represents the more strongly recommended genes for breast ovarian. The yellow means the less strongly recommended for breast ovarian. And the red means the more strongly recommended for other cancer types. And then the green represents the genes actually associated with specific cancer syndromes, but not including ASCO guideline. And then the purple represents the genes that has therapeutic implications there. So as you can see here, there's about 15%, additional findings, compared to what if we follow strictly the ASCO guidelines. So this shows there is a benefit to go broader gene testing here. But again, we have to balance with the potential harms there. So the next step we plan to do is actually investigating the VUS variant of uncertain significance burden in this patient cohort to starting rate understanding, what's the potential harms associated with the broader gene testing here. With the continuous decreasing cost associated with the genetic testing and population genomic screening is close to become a reality. It was envisioned almost 20 years ago with the publication of the first draft human genome sequence. Population genomic screening is recognized by the CDC as having notable potential to improve public health. So there have been some studies conducted in the U.S. to actually understand the utility of population genetic screening. I list the three examples here, the Geisinger MyCode projects, Healthy Nevada projects, and the Healthy Oregon projects here. As you can see, if we combine them together, about 1% of the U.S. population could be carriers of the pathogenic or likely pathogenic variant in the CDC Tier 1 cancer conditions here. If we expand the gene list to including the cancer genes in ACMG secondary gene families, that percentage goes up to 4.5%. So another one remaining question here needs to be addressed is the cost effectiveness, right? There's some modeling suggesting, if we drive down the screening cost down to the low hundreds, this could be a potentially cost effective. So I think I'm glad that we're not that far away from that target. So just to summarize, the ASCO guidelines provide evidence-based systematic recommendations for germline cancer genetic testing for patients with cancer, emphasize the importance of the family history, and it provides a specific gene list that you should consider based on the specific cancer profile of an individual patient here. And also broad gene panel can be considered, but also should be carefully balanced with the potential harm there. And also emphasize the importance of the pre and post testing counselings, including explaining of what genes will be tested, and the benefits and the limitation of genetic testing, and the possible outcomes, the familial implications, and the facility and cascade testing in other family members will be important. And all this, really points out that genetic expertise is really essential for the correct interpretation of genetic testing results. Although the ASCO guidelines marked a significant step forward addressing the pivotal aspects of germline genetic testing in patients with cancer, they don't fully address the areas like pre-symptomatic testing and also the upcoming future trends such as universal cancer screening, universal genetic testing for cancer or population healthy screening. So in here, just the last slides show you some additional, resources that you can use to learn more about the ASCO guidelines, including the podcast and also the free ASCO guideline apps here. And we also list the 3 relevant, ASCO guidelines for your reference. I think with that, we happy to answer any questions you might have.
Thank you, Dr. Shen and Ms. Lehner. That was outstanding, very informative. We now have a few minutes for questions. So at this time, I'd like to open this up to the audience for questions. And it looks like we just had one question come in. It's from an anonymous attendee who says, for a patient with unreliable or limited family history, would you consider a broader gene selection?
I can take that, Dr. Shen. I do think the answer is yes in that circumstance, based upon that recommendation, the strong recommendation, the second one we covered there, recognizing that family history essentially can be unreliable or not discussed openly among families, that using the opportunity then to capture as much information as possible in those circumstances is really beneficial for that particular patient, because there have been a number of those cases which have been identified with predisposition to hereditary breast and ovarian cancer syndromes, associated cancers, or Lynch syndrome, which were not thought about prior to that. And so based upon this recommendation, I would say the answer is yes. Doing a broader panel, as long as the patient is understanding and has a tolerance for that type of potential for uncertain results, is beneficial.
Well, thank you. That's an excellent answer. We're just about at the top of the hour, so I'd like to thank everyone for participating into today's webinar and remind you that laboratory credit is extended for this program. So upon finalizing your evaluation, you'll have the opportunity to claim credit and print your certificate. Thank you, everyone, for joining us today for today's webinar, and have a great day.
Thanks, everyone.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.